Hello everyone, and welcome to this next lecture regarding the case history in which we are discussing about chest pain, shortness of breath, and tachycardia in a young patient. So we were talking about benign early repolarization in our last slide in context of the ECG changes in this patient, and we were mentioning that there were ST elevations, and in a young patient with otherwise no risk factors or no cardiac abnormalities, the BER or benign early repolarization is the most likely cause of these changes. So widespread ST elevation in this condition, benign early repolarization, may mimic pericarditis or acute myocardial infarction. Up to 10 to 15% of the patients presenting in the emergency department with chest pain have BER on their ECG, making it a common diagnostic challenge for the clinicians. BER or benign early repolarization is less common in patients more than 50 years of age and is particularly rare in those more than 70 years. In those patients, the ST elevation is more likely to represent myocardial ischemia. The physiological basis of BER is poorly understood. However, it is generally thought to be a normal variant that is not indicative of any underlying cardiac disease. However, recently a link has been established between the global BER pattern and future risk of idiopathic ventricular fibrillation. The clinician should avoid diagnosing BER in patients more than 50 years of age, especially those with risk factors for ischemic heart disease like hypertension, smoking history, or raised cholesterol levels. In those patients, usually an underlying coronary artery disease is responsible for these ECG changes. So what are the basic salient features in the ECG of benign early repolarization? We have discussed this earlier as well, but we will talk about it in a little bit more detail. ST segment T-wave morphology. The ST segment T-wave complex in BER has characteristic appearance. There is elevation of the J point. The T-wave is peaked and slightly asymmetrical. The ST segment and the ascending limb of the T-wave forms an upward concavity. The descending limb of the T-wave is straighter and slightly steeper than the ascending limb. The concept of smiley-shaped ST elevation was popularized by Ken Grossier in 1993 is worthy of mention. So typical morphology of BER includes T-wave morphology and ST elevation, which is smiley face. As you can see from this slide, there is a smiley face there which is corresponding to the features we have just discussed. The ST segment elevation is visible. As you can see, the elevation of J point is seen. The T-wave is peaked, slightly asymmetrical. The ascending limb of the T-wave forms an upward concavity as well as the ST segment. The descending limb is straighter, steeper than the ascending limb. So this can be used to remember the features of BER. J-wave or J-point morphology. One characteristic feature of BER is the presence of a notched or irregular J-point. This is called fish hook pattern, and this is best seen or appreciated in lead V4. So as you can see there, this is the slide where there is a visible notching of the J point, and this is termed as the fish hook pattern, and mostly you will be able to appreciate it in the lead V4. So with this we conclude this slide of this lecture on a young patient presenting with chest pain, shortness of breath and tachycardia. I will take up more details in the next lecture. Thank you very much for watching and see you in the next slide.